Great. Hi, everybody. This is Dr. Maureen Nash, internal medicine physician and geriatric psychiatrist. So today I'm going to be talking about delirium, dementia, and depression, which sort of from an airplane view can often look very similar, but once you change your eyeglass prescription or focus your binoculars, then it becomes really clear how different they can be. And so this webinar is really focused on kind of recognition, differential diagnosis, and doesn't move on to some of the important treatment details. I have no financial disclosures. I'm not planning particularly to talk about medications, but if they come up in the questions, I will be sure to mention whether things are FDA approved or not. And this program is supported by Central Oregon Health Council. Next slide. Next slide, maybe.
I'm sorry, Maureen. I am advancing the slides. Are you not able to see the change?
I can't. I've just got the disclosure slide up.
Okay, let me unshare and try again.
It's a live show, folks. Technical difficulty.
Okay.
Great.
Well, I'll keep talking if you put the learning objectives up, and I'll go from there.
Okay.
So really, I'm going to talk about and help people focus their thought process on what are the central deficits in these three different diseases, because they really are quite different. So there are central deficits in delirium. There are multiple deficits in both dementia and depression that are central to the diagnosis. And then hopefully at the end, you will be in a better spot for differentiating and understanding these different diseases. Next slide. So the basis for any of these sort of understanding any psychiatric disease or really any neuropsychiatric disease is to look at the domains through the DSM-5. They break them up, cognitive domains. They break them up into 6 different groups. So there's complex attention, which has to do with your ability to divide your attention between multiple things, your ability to sustain your attention on something that you are particularly interested in or something that is particularly important or dangerous, for example. And then selective attention, which is the ability for you to actually control what it is you are able to attend to. And so those are 3 different types of attention, and complex attention involves being able to maintain all of those different abilities. Then there's executive functioning, which is arguably that's what makes us really smart mammals, if you will. The executive functioning involves some very high functioning frontal lobe abilities, but it is also quite dependent upon everything else in your brain working well. So if you are having lots of problems with other brain areas, then executive functioning isn't going to be able to do its job to the best of its ability. And executive functioning, when we talk about that, you might hear that phrase a lot, but what that really means is, among other things, it's our ability to plan, it's our ability to make decisions, which includes evaluating all the choices and all the information that we have in order to make a decision. And all of that, of course, depends upon working memory, so the ability to hold multiple different thoughts and memories in your head at the same time. And an important and somewhat under-recognized part of executive functioning is the ability to inhibit. And this is actually very essential. It's your ability to inhibit extraneous details or distractions or things that aren't relevant or things that you've already thought about and decided, don't need immediate attention. So you inhibit those thoughts so that you can focus and make decisions or plan for whatever it is that you wanted to make happen. Error correction is really very important, and that's sort of our ability to, when we have thought things through, made a decision, and made a plan to execute the decision, and we've started that process, what if something unexpected happens in the environment? Or what if what we're doing we realize isn't going to get us to where we want to go? Then you really need the ability to recognize that and then modify your course of action. And that's error correction. And it's an amazingly complex and sophisticated function. And then finally, flexibility, mental flexibility, and emotional flexibility. Those are both parts of executive functioning. So you can see why that is so important as an area of the brain. Learning and memory, that's kind of the most obvious thing that comes up, for instance, when we think about dementia often, because the most common kind of dementia, Alzheimer's disease, and the second most common kind of dementia, Lewy body dementia and Parkinson's disease dementia, all of those involve impairments of different sorts in learning and memory. But learning and memory has multiple parts to it. There's the working memory again. There's short-term memory, explicit and implicit memory, and then semantic. And they all work together and are really essential in our ability to learn new things and to implement new knowledge into older things that we already knew. Social cognition is one of those harder to comprehend sometimes, I think, brain areas of functioning. But it's one of those things, you know it when you see it. So social cognition is our ability to recognize emotions in others, in other mammals, in other people. It's our ability to take somebody else's perspective, our ability to recognize and process our own emotions, and it involves sort of the very sophisticated psychological concept of theory of mind. Then the last two areas of cognitive domains, there's perceptual motor, which has to do with construction, the ability for you to visualize things in 3D, or if you add in movement, 4D, if you will. Your ability to understand where things are in space, your ability to recreate things in space, your ability to perceive visual stimuli and process that appropriately. Nausea, which is about recognition, so it could be facial recognition, recognition of other people as well as objects. And then praxis, which is sort of those things that we learn how to do, like using a tool or driving. And when you have trouble doing something that you have learned how to do and done a lot, so it's overlearned knowledge, that would be an apraxia in that area. And then language, of course. And there's lots of different ways to slice up language, but a pretty common way is to look at expressive language, receptive language, and then grammar and syntax. Next slide. So first we're going to talk about delirium. Next slide. One of the key things about delirium is that it is underdiagnosed. The diagnosis for delirium is clinical. It does require careful bedside evaluation, and you do need to assess cognition as part of your general assessment. One of the challenges with it is, by definition, it fluctuates. So it's present at some It's present in a significant, noticeable, obvious way at some points during a day and less obvious at other points of the day. It's easily confused with dementia, and often they occur together. So it's not like they're mutually exclusive, but they are quite different. The significance, I think, of delirium and its close relative encephalopathy is that I'm not sure that we all understand how the impacts of these things can be, as far as what the long-term sequelae are. And then, of course, like everything else, if you don't think about the diagnosis and you don't consider it, then you're not going to find it, most likely. Next slide. So one of the most well-known ways to look for delirium is the confusion assessment method. It's well validated in research settings, and when implemented by physicians or other healthcare providers, it has good sensitivity and specificity. And so you have to have an acute onset and a fluctuating course, and then you have to have inattention, deficits in complex attention, and then either disorganized thinking or an altered level of consciousness. So, where people are somnolent at unexpected times or not. It is what is used in studies and is thought of as the gold standard, but it's really a yes-no thing. So it doesn't actually help you determine whether this is a mild, moderate, or severe case of delirium. And it's been around for a long time. 1990, Sharon Inouye and her group developed it. There are various forms of it. The most commonly used, I think, is the CAN-ICU form. Next slide. So that's kind of what they use in studies, but at bedside practice, that's a little bit more challenging. And so the VA has a delirium toolbox that you can easily find online, and they have the modified RAS scale, and this involves, they actually tell you how to do it, so it's, I think, a little bit more user-friendly, for instance, than the CAM. You observe the patient. Are they alert, restless, or agitated? You score that. If they're not alert, you say their name. If they can open their eyes and look at you, in other words, if they're able to attend to you and to the noise that you're making, then you ask them, describe how you're feeling. And then they tell you how to score that and what various options are. So the person awakens, they make sustained eye contact, they keep their eyes open, or they awaken, they open their eyes, they make eye contact, but they don't sustain it, or the person has any movement in response to your standing there and you're saying something, but they don't make eye contact. And then if there's no response to the verbal stimulation, you do the shake, gentle, of course, on the shoulders or rub the sternum, and look to see if there's any response. And then the VA has this, next slide, has this very nice little diagram that you can kind of carry around in your pocket if you have it on a little card, and you can kind of score a person on that. So anywhere from, and you'll see that the two ends of the spectrum on that are combative down to totally unresponsive. And next slide. And those, I think those are very helpful. What I find when I'm assessing for delirium to actually be the most helpful in just everyday life is the bedside screen of month of the year backwards plus or minus the spatial span forward. And then you just look for, is the person confused in the judgment of the nursing staff, in the judgment of any support or family, natural supports that a person has, or in your judgment as a provider. And this has been studied. This is one particular study where they looked at months of the year backwards and spatial span forward. And what they found was months of the year backwards had really very good sensitivity and pretty decent specificity for delirium. And so people who were 70 and older, you just need to do months of the year backwards. And of course, the most important thing when you're doing that is to first start, can you tell me the months of the year forward? And one of the nice things is that really works in the vast majority of languages. Almost all languages have 12 months. So if a person can say them forward, then you ask them to say them backwards. And for an older adult, that is enough to assess attention. And you'll notice there's many things. There's working memory, lots of things, different parts of that. When a person is younger, then you also want to do 5 digits forward and then get them to repeat those 5 digits forward and then ask them to repeat them backwards. And so if you use this bedside screen in addition to the CAM, you get better specificity but less sensitivity. So I have found that this is a great screening tool. And again, like the CAM, it's not going to help you necessarily in judging whether this is mild, moderate, or severe, but it does help with present or not present. Next slide. So if you want to look at the sort of criteria for delirium, you can see that the CAM is closely modeled on the DSM-5 criteria for delirium. There's the rapid and abrupt onset of impaired attention and lack of awareness of environment. You have to have a change in at least one cognitive domain, and that being memory, orientation, language, or perceptual disturbance. And generally speaking, they're referring there to, say, visual hallucinations or misinterpretation of visual information, or sometimes auditory hallucinations, less commonly. And then there are associated features that we often see in delirium. You often see a change in the sleep-wake cycle. You often see emotional lability and a worsening of behavior problems in the evening. There are a number of theories about the later evening being more stressing or distressing. I myself am in the camp of many people who think that's related to fatigue as the day goes on. And then next slide. And finally, we often talk about types of delirium. So there's hypoactive, hyperactive, and mixed, alternating between the two. Just like I mentioned, I don't know if you advanced to that slide because I seem to be having a lag on my visual there, but so the types of delirium. Interestingly, the type of delirium as far as hypoactive, hyperactive, or mixed doesn't really correlate to specific treatment protocol, although we often treat these 3 types differently, or we tend to treat hypoactive by watching, and we tend to treat hyperactive or mixed more actively. Next slide. Then, of course, the usual or common course. Abrupt, reaching a full syndrome within 1 to 3 days. often very early, you just see this restlessness, irritability, anxiety, and sleep disturbance. And then in a fulminant case, it progresses pretty quickly to stupor, coma, seizures, or death. And there are sort of three outcomes. There's recovery, full or partial. There is dementia or death. And so, next slide. There are different deficits that we see in delirium. And so there's anatomic deficits that you can see depending on how you study the brain. And then there are neurotransmitter imbalances that are seen. I do want to point out to everybody that delirium is a syndrome. It is unlikely that it is exactly the same thing happening in every person's brain. And that's one of the reasons why studies for treating delirium, I think, have kind of confusing and conflicting results. Because delirium is clearly a syndrome, and there's not, it's not like everybody who is delirious has the exact same thing going wrong in their brain. Different people have different things going on in their brain, although as the delirium worsens, once you get to a point of global severe dysfunction of the entire brain, then it can look then probably a very similar thing is going on in everybody's brain once you get to that point. But the pathway that different people, different clinical courses take to get there changes. Next slide. Common causes. I know everybody has probably seen this kind of a list. I just really want to highlight three that are really important with older adults and exceedingly common and underappreciated. One is dehydration. The older brain is extremely sensitive to dehydration. And so if you spend any time with me, you might hear me say the hydrated brain is a happy brain. There is, if a person has good kidneys or even halfway decent kidneys, hydration is really important for cognition. And the older you are, the more important it is. And then urinary retention and fecal impaction are quite common in the inpatient environment and in the nursing facility environment. And those are two underappreciated and under-recognized causes of delirium, which are relatively easy to help with if you consider them and recognize and treat them. Next slide. Just a little review of, there's real challenges with the literature. And, there was a recent, actually, I think it was Annals of Internal Medicine and not JAGS, meta-analysis on the treatment of delirium that got a lot of press about evidence for the use of one particular class of medicines that has been shown in multiple prospective randomized controlled trials to be helpful for a number of people with delirium. And they sort of did a meta-analysis of many, many different trials, including things that weren't randomized controlled trials, and concluded that, they didn't think that that class of medicines was evidence-based. Of course, a meta-analysis of randomized controlled trials is no longer randomized, no longer controlled. So I actually, there are many of us who sort of doubt the meta-analysis that was just published, but it did get a lot of press. Next slide. So it's quite prevalent, and acute delirium often turns into subacute delirium. Okay, next slide. Why do you care about delirium? This really is arguably one of the most important slides in the presentation here. This was a very well done, though just a single study of about 400 people, post-acute care folks at a SNF, average age of 84, so the perfect demographic for looking at delirium. And what they found was that functional recovery differs significantly by delirium resolution. So people whose delirium was recognized and resolved completely within 2 weeks without recurrence regained 100% of their pre-hospital functional level. Whereas those who did not resolve their delirium symptoms in 2 weeks, they were only able to attain less than 50% of their pre-hospital functional level. And this is one of the most powerful studies that I've ever seen that I would recommend clinicians take note of. So it's important to look for, and it's important to treat it to resolution, and really try consider carefully the risks and benefits of watchful waiting, which does tend to be a pretty common method, I think, for hospitalists in particular. So it really, there are lots of reasons to think that it matters. Next slide. What is depression? What's the illness? So major depressive disorder, and it looks like I have some, so major depressive disorder, it is pervasive, persistent, and has a wide range of symptoms. Next slide. What are the symptoms of depression? Next slide. So the range, we have negative views, worthlessness, incapacity, guilt, sleep disturbance, diurnal mood variation, loss of energy, and impaired concentration. There's a lot of different acronyms out there to help you remember all these symptoms. The key thing, one of the key things about depression are really sort of the next slide, which is the functional impairment. There's an impaired work ability. There's impaired social functioning. In moderate or severe depression, we often see psychomotor retardation and pessimism, or sort of this negative filter so that you're not able to think positively about things. It's like every time a thought comes into your head, what you notice are negative connotations, feeling like you're better off dead, having thoughts of death and or suicide. Suicide being one of the worst outcomes of poorly treated, untreated, or unresponsive to treatment, major depressive disorder. And another sort of in older adults, especially, we often have this fear or belief that we're having all sorts of bodily illnesses. Next slide. There are various things that can increase our risk of depressive illness, and these include losses, stressful life events, lack of social support, physical illness, familial factors, genetic factors. And what you'll notice about these is that they're all probably adding to our stress, to our fight or flight, our sympathetic nervous system. That's the part of the brain and the central nervous system that these types of stressors probably are leading into and activating outside of genetic factors, which can impact that or other parts of brain functioning. Next slide. I'm just going to go over the ICD-10 criteria for depression. There are lots of there's screening tools out there. There's geriatric depression scale. There's the HAM-D. There's the PHQ-9. ICD-10, I think, has pretty nice criteria, and it has a nice way to score it for mild, moderate, severe, and that makes your coder happy with you when you code your major depressive disorder appropriately. So their questions, does the patient ask them, do you have a low mood? And then they give you specific questions and to ask. If the answer is yes, then move on to the next questions. Have you lost confidence in yourself? Do you feel guilty about things? Are you having concentration difficulties, sleep problems, change in appetite or weight? Do you feel that life is not worth living anymore? That's a particularly telling question. And it's a much better question, actually, than asking people if they're having thoughts of killing themselves. A person who is actively suicidal is probably less likely to tell you that they're thinking about having thoughts of killing themselves, but they are more likely to answer this question accurately. Do you feel that life is not worth living anymore? Next slide. And then, how do you score it? Mild, moderate, or severe? Then next slide. There are other variants of depression besides major depressive disorder. And so there are depressive episodes that do not meet criteria for full major depression. If a person has a past history of major depressive disorder, this should be considered a recurrent event of that. But if they don't have a past history of major depressive disorder, then it may very well not be the same disease process. About 50% of people who have major depressive disorder find that it's a lifelong disease. And a significant subset of people who have major depressive disorder kind of never reach full remission, and they have kind of chronic low-level, mild to moderate depressive symptoms, which is called dysthymia. A number of people have mixed states of above 2 or major depressive disorder and dysthymia, and they alternate between the two. 50% of people who have an episode of major depression do recover from that and do not experience other episodes. So it's sort of people kind of fall into two camps. About 1/5 of the population or 20% of the population will experience a major depressive episode at some point in their life, but it's the recurrence of it that really helps see which kind of camp a person falls into long term. When older adults have a major depressive episode, the most notable cognitive impairment that they have is in executive functioning or frontal lobe functioning. And so it's the executive functioning skills, and that impacts the ability to make decisions. It impacts the ability to course correct, for instance, as well as the ability to, accurately perceive risks and benefits of things. And that's one of the reasons why major depressive disorder is so disabling in older adults. Bipolar disorder, of course, some people with bipolar disorder only have recurrent manic episodes, but then there are the more common types of bipolar disorder that involve significant major depressive episodes. There is a concept called minor depression, which is where you meet some of the criteria for major depressive disorder, but 4 or less, rather than 5 or more, if you want to look at the DSM-5 criteria. One of the key things about minor depression is that those folks tend not to benefit from antidepressants, but they do benefit from supportive interventions, psychosocial interventions, increasing socialization and social support, and psychotherapy. Sort of last but not least, a lot of people talk about depression, but what they really mean is sadness. And it is important both in our clinical notes as well as in our discussion with people to differentiate, because sadness can be very distressing, but it's fortunately not an illness itself that is going to affect your whole brain. Next slide. So, diagnosis and differentiating things, it's a lot easier if it all fits on a microscope slide and the pathologist can look at it. Although I'm not sure that I would trust this pathologist. Next slide. Is the diagnosis of major depressive disorder missed? Well, when they do studies, this is from one particular study, but it's been replicated. About 50% of cases are missed. And of those 50% of cases of major depressive disorder, about 10% are subsequently diagnosed. Of the 40% who are never recognized, what we see is about half of those remit spontaneously and half of those are depressed 6 months later. And that's actually kind of similar to just sort of the statistics for recurrent major depressive disorder, right? So half of the people have one episode and then it remits, and half the people continue to have symptoms or have recurrent disease. Next slide. So what might lead to a misdiagnosis of major depressive disorder? Well, there's certain things about patients that can impact that. So one of the most common in primary care and possibly in hospital settings, inpatient settings, is that people present with somatic symptoms. And this is, in some cultures, is more present than others. So the somatic symptoms, for instance, in some Mediterranean cultures or some Asian cultures, people are more likely to present with somatic symptoms. Physical problems, so when people present with a physical complaint, when people present with physical symptoms and they are sort of not easily explained or they don't fit with a diagnosis, one of the things to consider is this major depressive disorder. Of course, stigma has impact there. People don't want to have a mental illness and so don't want to see things that way. A lot of people believe that their GP or PCP don't want to hear about their symptoms and won't take the time to listen to them. Someone has had long-standing, but they felt like this for years or decades even. So it's like this is normal. So they don't recognize it as abnormal. If somebody has less typical symptoms and don't present with them, and if someone doesn't have insight. Next slide. Then there are other things that lead to misdiagnosis, and these have to do with providers. So we can divide providers up into sort of two categories: people who are more accurate diagnosers and people who are less accurate diagnosers. And I just review these because they are things that we could change about ourselves so that we could be more accurate. So more accurate diagnosers make more eye contact, show fewer signs of being in a hurry, are good listeners, and ask questions with social and psychological content. Less accurate diagnosers ask closed questions and then sort of are going from a checklist, do you have this, do you have that, rather than kind of listening to what a person says and following up with that and kind of having the conversation flow more naturally. And I think that some of that probably has to do with experience, like how many people you've met with a particular disease process, as well as, is this your first year of practice? Have you been doing this for 30 years? But I think it is helpful to look at that list because some of these things are easier, are somewhat easy for us to control. Next slide. So how do you know whether something is delirium or whether it's a dementia, a major neurocognitive disorder, for instance, or a minor neurocognitive disorder, which is a dementing process that has not advanced to having functional impairment yet? Well, again, the key focus, the key criterion for delirium is this disturbance in level of awareness and attention. Attention deficits are the central deficit in delirium. And however, as mentioned earlier and mentioned again, you can have both. You can have delirium as well as a progressive neurodegenerative neurocognitive disorder. Next slide. So if you want to look at dementia, kind of by definition, we think of the things that cause dementia as being attributable to changes in brain structure, function, or chemistry. Etiologies of these syndromes, when they're known, we can code for them. And then what differentiates what we call minor neurocognitive disorder from major neurocognitive disorder is functional decline in abilities to do independent activities of daily living and then activities of daily living. So that's really what moves something into the dementia category, is once you start to have challenges with IADLs and ADLs. Next slide. The DSM-5 criteria for neurocognitive disorders and dementia, they really focus on two areas, core deficits in cognition and then decline in functioning, in cognitive functioning, and it has to be a decline from your previous level. So as opposed to, for instance, maybe somebody who was born with a developmental delay, they may have overlap in symptoms and presentation to somebody who has dementia, but it's not new for them. Next slide. So those are the two things that DSM-5 looks at, and they really call out some of the types of neurocognitive disorders that we can, at this point in time, really define fairly well. They call out Alzheimer's, Lewy body, frontotemporal, vascular neurocognitive impairment, traumatic brain injury, HIV, Huntington's. So next slide. What the DSM-5 sort of puts in a subcategory of descriptive features are psychosis, mood disturbance, apathy, agitation, and then sort of other behaviors. What I would say is I actually think that these are much more central. The World Health Organization and its conceptualization of dementia sees it as kind of sitting on the tripod of cognition, behaviors, and functioning. And so rather than just sort of that being something that you describe it with, and of note, if you look at longitudinal population-based studies, the use of antidepressants, antipsychotics, anti-anxiety, and hypnotic agents, all of those increase in the decade before somebody develops and or is diagnosed with dementia. So I actually, along with that World Health Organization, think that these symptoms and signs are much more central to the disease process rather than just sort of an associated problem. Next slide. I'm just going to briefly breeze through some of the major types of dementia. So Alzheimer's disease, we know about the decline in memory and learning, and then there's this steady progressive decline. So when they say steady progressive decline, they're talking about a steady cognitive decline. However, if you look at the functional decline with Alzheimer's disease, it is not quite so steady in the same way. Functionally, what you see is a very slow functional decline in the mild stages, then when you're in the moderate stages of dementia, there's a pretty rapid 2 to 3 year functional decline. And then once you're in the severe or advanced stages of Alzheimer's, there is the rate of decline slows again. And clinically, what we see in Alzheimer's is this challenge forming new memories, and then a total inability to form a new memory, as well as visual spatial challenges, for instance, getting lost in familiar areas and word finding problems. Frontotemporal lobe dementia, there's 2 different variants. Next slide. There's the behavioral variant and then the language variant. There's relative sparing of learning and memory and perceptual motor functioning until people are in the moderate and moderate to severe range of frontotemporal. And so that's why this can be a challenge to recognize, because a lot of times when we think dementia, what we're really thinking is Alzheimer's, and we're looking for that trouble with new memories that you don't really see in frontotemporal dementia the same way. Next slide. Lewy body and Parkinson's disease dementia, which is a subset of Lewy body dementia. You've got the fluctuations within a day that kind of can look a little bit like delirium, because you can have these fluctuations in attention, alertness. There's often recurrent hallucinations, spontaneous features of Parkinsonism. And then there are suggestive features that go along with Lewy body. There's REM sleep behavior disturbance and a severe neuroleptic or antipsychotic sensitivity. Next slide. Vascular neurocognitive disorder. I think that one of the challenges with clinicians that I see is anytime somebody has vascular risk factors like high blood pressure or heart disease, they are more likely to end up with a diagnosis of vascular dementia, even though they may have a different type of dementia. Vascular risk factors are also risk factors for Alzheimer's, for instance, in addition to vascular dementia. I would point out, though, vascular dementia, you do have this complex attention, especially processing speed. Next slide. So I just got a question about elaborating more on minor depression. So minor depression. So I actually went over the ICD-10 criteria for making a diagnosis of major depressive disorder. But if you look at the DSM-5 criteria, so that I think most of us learn in medical school for diagnosing major depressive disorder, you have to have anhedonia or depressed mood, and then you have to have 4 other symptoms from that list of thoughts of death, excess guilt, psychomotor slowing, weight change, sleep changes, especially early morning awakening or mid-cycle awakening, etc. So the minor depression is actually when you meet criteria, we only have 4 of the symptoms, 4, and so you don't actually have at least 5 symptoms, which is major depressive disorder. So minor depression, when people say minor depression, and you can find it in the literature when people talk about it, that's what they're talking about. They're talking about somebody who has notable depressive symptoms, but they don't meet criteria for major depressive disorder. They almost meet criteria for major depressive disorder. So that's what minor depression is. And the only reason to note that is just, I think it's worth mentioning that doesn't generally respond to antidepressants. And I think there is I think people have lots of hope that antidepressants will help us. So, and then finally, neurocognitive domains. Next slide. Oh no, you already have it up. So let's go back to the neurocognitive domains. How do you differentiate between delirium and dementia with agitation? So hopefully that people will have some thoughts about this. Now you've seen the slides, but with delirium, you have to have deficits in complex attention. You have to have problems with divided attention, sustained attention, and or selective attention. There is a waxing and waning. Generally speaking, there is a medical or neurological etiology for delirium. However, there is the caveat, we don't always find it. So just because you can't find the cause doesn't mean it's not a delirium, but it does make it more challenging to treat it. Dementia with agitation, if you mean dementia with psychomotor agitation, there's no reason to think that that is delirium unless you have a new and different attention deficit. So if somebody has very advanced dementia, they might have impairments in attention, very advanced Alzheimer's, for instance. But if a person doesn't have very advanced dementia, their attention is usually intact in mild and moderate Alzheimer's disease. And so that's actually one of the biggest things. Plus, people aren't acutely ill. Once a delirium takes hold, I didn't really review you get vital sign changes, and you can get heart rate, high heart rates and low heart rates, as well as blood pressure and respiratory rate changes. So yeah, delirium and dementia with agitation are quite different. Delirium has an acute onset. In somebody who has dementia, you generally are probably seeing dementia with behavior disturbance rather than delirium. So, can a person with another disorder be misdiagnosed with manic depression? For example, with ADHD, is that common? So, a person can present with a picture, right? So you do your assessment at one moment in time, and we, in medicine, for the last, couple thousand years, what we do is we develop a list of possible things that might be causing the problem, and we have to make a decision about what we think it is. We have to make a diagnosis, especially if it's a moderate or severe problem. You can't just watchfully wait. If it's a minor problem, sometimes you watchfully wait and you see how things progress, and that's how you make a diagnosis. So yes, could somebody have an inaccurate diagnosis at a moment in time for bipolar disorder versus ADHD, or for dementia versus delirium? Yes, at a single moment in time, but that's why the history, especially recent history, as well as what happens next, that's how you determine a diagnosis. And so sort of what often happens with things like schizophrenia and bipolar disorder is that we diagnose people and then we follow them, and then over time what they actually have becomes more obvious. So that's that. I'm just going to go back for a second. So complex attention, think delirium. Executive functioning impairments, think major depressive disorder in an older adult, and then think, is there evidence of significant functional decline? Is there a long-standing history that suggests dementia? You want to look for that. Learning and memory, you want to look at Alzheimer's disease, maybe vascular dementia. Social cognition, there you want to look for major depressive disorder or frontotemporal dementia. Perceptual motor, the first thing you might want to think about is this Alzheimer's disease, and then language. So there, depending on what other things you see, you might think frontotemporal, some of the language variants of that, which are relatively rare, but they're quite obvious when you do see them. Or then if the whole picture is much more like Alzheimer's disease, and then finally stroke. So I think we are about at the end of our time. How can you tell the difference between vascular dementia and regular dementia? Well, I'm not sure that there is such a thing as regular dementia, but there's dementia of different. Dementia is an umbrella term, so it doesn't really tell you. 80% of the time when somebody says dementia, a person has Alzheimer's disease. They may have other types of dementia in addition, but most of the time what people are thinking of is Alzheimer's disease. And so when people say, quote unquote, regular or common dementia or garden variety dementia, they're usually thinking of Alzheimer's disease. Vascular dementia, I tend to diagnose when people have had significant strokes that are big enough to show up on a CAT scan or an MRI, a CT or an MRI. I think it's very unusual to have microvascular changes leading to, which are sort of what sometimes they call tiny strokes or small strokes, leading to dementia. I think that's exceedingly rare, and what you really have in those cases is usually Alzheimer's disease.